Hello, everyone. We're excited to have you here for NETEC's webinar on clinical perspectives on home testing and monitoring for high consequence infectious diseases. So NETEC's mission is to set the gold standard for special pathogen preparedness and response across the health system in the US. And the overall goal is to drive best practices, closing knowledge gaps, and developing innovative resources. And this webinar is one part of our outreach to the community as well, to share our knowledge and use our subject matter experts to expand further in key areas. Within NETEC, this mission is usually achieved through the collaborative efforts of 13 regional emerging special pathogen treatment centers across the country. There's more than 100 industry leaders representing a range of healthcare specialties, from infectious disease clinicians to emergency medical service leaders. And they share their expertise across NETEC's 15 national work groups and 9 task forces. And we're broken down into 10 different regional emerging special pathogens treatment centers that you can see here as well. And NETEC leverages the knowledge and experience of its regional partners to produce timely and innovative educational resources. It provides technical consulting and assistance, and it builds a nationwide special pathogens research infrastructure, and really it convenes global partners to spearhead the knowledge that we are able to gather and share with the community as well. So briefly, for what we're aiming to do today is we're going to review prior experiences of acute remote monitoring for infectious diseases. We're going to be discussing different models and key considerations of home testing and remote patient monitoring for high consequence infectious diseases, including the technology requirements, the scalability, and just the jurisdictional challenges as well. And we're also going to explore the ethical, safety, and experience implications of remote monitoring for high consequence infectious diseases. For this, we have a wonderful panel of speakers that are going to be joining us. And we're going to be starting with Dr. Moon Kim, who leads the Hospital Outbreak and Biothreats Response Unit within the Los Angeles County Department of Public Health's Acute Communicable Disease Control Program. And she's going to be speaking about the mobile assessment of low-risk travelers from VHF-affected areas. Then we're going to have Dr. Shane Kapler and Dr. Ethan Booker from MedStar, who are going to be joining, and they're going to be speaking on 2 different topics. One of them is the COVID-19 remote patient monitoring, and the other one's going to be their regional public health remote monitoring program. Dr. Kapler is the medical director of the biocontainment unit. He's the director of biothreats and the senior attending physician at MedStar Health. And Dr. Ethan Booker is the chief medical officer for telehealth at MedStar Health and is a senior attending physician in emergency medicine at MedStar Washington Hospital Center. And then we're going to have Dr. Gabby Frank, who's going to be speaking on Denver Health's virtual assessment model for at-home evaluation of suspected high consequence infectious disease cases. And Dr. Frank is a hospitalist and the medical director of the biocontainment unit at Denver Health and Hospital Authority. And at the end, we're going to have some time for questions and answers. And as I said, please ask your questions in the chat. We'll make sure to try to answer them. If there's interesting questions that we think it's appropriate for the entire audience to also listen in as well, we can discuss if there's time at the end as well. And for the questions that we're not able to get to, we'll make sure to answer them, and they will be shared on our website as well. So for our first talk today, we have Dr. Moon Kim. She's going to be speaking about the mobile assessment of low-risk travelers from VHF-affected areas. Thank you. Dr. Kim?
Hi, thanks. Can you hear me okay?
Yep.
Great. Hello to everyone, and thanks to NETEC for the opportunity to share information on LA County's mobile response. Next slide. So just as a background, over the past 10 years, the United States has used redirection of flights several times during VHF outbreaks in Africa with screening of travelers at airports and then monitoring by public health for 21 days. LAX was included, our airport, as one of the redirected airports during the first 2 times this redirection occurred. And I wanted to point out that a lot of these times it was during flu season and then also during COVID. And so hospitals and emergency departments were already busier than they usually are during these times. LA County has a very large population, and I show this to illustrate just how big it is, but also important in terms of looking at coordination and collaboration with our partners across our county. We have 97 acute care hospitals and 88 cities within LA County, and Cedars-Sinai is our Region 9 Special Pathogens Treatment Center. When redirection of flights and public health monitoring occurred during the outbreak of Ebola in West Africa in 2014, public health monitored about 10 to 25 patients a month. And over these couple of years, we monitored over 200 travelers for 21 days. And so if any of these travelers became ill, we did see we did need options for how to manage, especially low-risk patients and travelers who really didn't have risk factors to have Ebola, but nevertheless might need an evaluation. So to plan and respond to Ebola back in 2014 and through the past 10 years, we've been meeting with what we call our Emerging Infectious Disease Work Group. We've been meeting every month for the past decade to discuss drills, exercises, and response protocols. Included in our work group is our EMS, Public Health, Cedars-Sinai, Kaiser Permanente, Los Angeles Medical Center, and UCLA, who are our local special pathogens treatment center resources. And it also includes Children's Hospital Los Angeles, who provides pediatric expertise and consultation, and was also an Ebola assessment hospital back in the 2014 outbreak. Our work group also includes our high-risk ambulance providers who provide transport if a traveler needs hospitalization at a special pathogens treatment center, and they are also involved in our mobile response. Our work group also includes our state health department. So back during the 2014 outbreak, we did have some low-risk travelers who were transported to Ebola treatment centers and received Ebola testing. They didn't need ICU care, but that was the standard for high containment protocols that we had at the time. But we know that if low-risk travelers presented to EDs, there is understandable caution and concern about the risk of Ebola, and it can sometimes lead to delays in care. And we know of reports that there have been delays in care for low-risk travelers where providers or facilities really weren't comfortable managing and treating underlying illnesses without ruling out Ebola first. So in our emerging infectious disease work group meetings, the concept of mobile evaluation arose in order to have an additional option outside of the high containment inpatient setting for managing these travelers. So with all our partners, we developed protocols working with our public health lab, which is a part of the LRN CDC network, and our Public Health Emergency Preparedness and Response Division to do mobile assessment of travelers who were ill and to collect specimens when indicated. And this was really a joint effort with our great partners, including our EMS and our clinical partners at Kaiser and Cedars-Sinai. So initially, what we really wanted to do was minimize patient discomfort and the direct disruption of hospitalization, especially when it wasn't clinically indicated, while safely ensuring that they received the care they needed. And secondarily, this type of mobile assessment minimized impact of operations at the Special Pathogens Treatment Center and would also expedite lab testing because specimens could be collected and obtained by the mobile team. I want to emphasize that this type of response is for a specific type of situation where the traveler is low risk, doesn't have any wet symptoms like vomiting or diarrhea, and the home is conducive to doing a mobile response. We do an assessment beforehand with the patient to get an idea of the home environment and concerns like accessibility for the team, privacy concerns, and also contingency planning if the patient's symptoms progress. We work in coordination with our health officer and state and CDC, and we also communicate with our special pathogen treatment center so they are aware of the patient and their potential to be activated. Even though we had developed it back in 2015, the teams were ready to respond each time in subsequent redirected flights and funneling of travelers in 2022 and 2024, most recently for the Rwanda outbreak. We never had a high-risk patient or actual Ebola case, but we did have a pregnant survivor deliver in LA County. And I mentioned this person because they presented at a time years ago when a nurse in the UK was reported to relapse with Ebola in the CSF. So even though this pregnant woman didn't have any signs or symptoms of Ebola and had recovered with a negative Ebola test taken in Africa 22 weeks prior to becoming pregnant, we did want to make sure that we did have a negative Ebola test, and we had to think thoughtfully and plan out how we would do this and what options we had with using the proper PPE, because although this person was considered to be extremely low risk to zero, we had to consider the specimen packaging, the transport, and logistics. We did end up drawing the labs at her home. When public health gets notified of a suspect VHF patient, we determine if testing is indicated and whether mobile assessment would be feasible. If not, we activate our treatment centers. And these are photos of our high-risk ambulances that we have in LA County. They have separate air handling for the driver and patient areas, and the entire patient compartment is non-porous for decontamination purposes. All deployments for the mobile response are done in partnership with EMS, the clinical teams at Kaiser and Cedars, and then with public health. These are the main sections of our mobile assessment protocol. In addition, Kaiser, EMS, and Cedars have their own specific protocols for PPE, their personnel, and for clinical care. But overall, in the protocol for mobile response, we have sections on assessing the patient's risk, criteria for mobile response, which includes the home environment, things like, are there other people in the house? Is there private access for entry? Any obstacles? Making sure the patient is comfortable with home specimen collection. Are there any children or pets? Language barriers, compliance with post-collection instructions, any social needs or issues, and how to handle waste. Also included are instructions for specimen packaging and compliance with self-isolation. And because we're public health, we might start assessing the contacts as well. So here's some of the appendices. We have our waste log, our instructions, and also guidance for the patient while awaiting test results. So once a decision is made that the mobile assessment will be done, our clinical partners conduct their patient evaluation via video, and they can see the home environment. And then we also have a coordination call with all our partners, including discussion of a potential staging area near the home where we can all meet first. And then we deploy the team. Usually on site, public health also provides our own PIO, our environmental health expert to serve as a safety monitor, and a public health lab staff member is also on site. Here's some photos of the exercise that Kaiser did, showing their PPE ensemble. Kaiser and Cedars have key personnel, including a minimum of a physician, a nurse, and a safety officer that enter the home, and then a trained observer and doffing buddy to be present at the doffing location. Here's some other photos done during one of the exercises, and in the bottom left, there's the home environment that they did do the specimen collection in. I also wanted to mention that this type of response was recognized nationally 2 years ago with Kaiser by the National Association of County and City Health Officials as a promising model or practice in response to a critical health need. So some of the strengths of the mobile assessment include that it provides an alternative option to activating a high-resource special pathogen center. It likely is less disruptive for the patient and provides a more comfortable situation at home while ensuring the proper clinical evaluation. It preserves critical inpatient assets for when they're really needed, not tying up treatment center resources on stable patients that don't need hospitalization. And contingency planning is also built in case the symptoms progress to be transported to a special pathogen center. And collaboration was fundamental. We really have great partners who are so dedicated and wonderful to work with, both at Kaiser and Cedars. Obviously, without them, we wouldn't be able to do this type of response. So the strong partnerships, development of collaborative protocols with all the agencies and facilities, along with our shared vision and collective expertise to run this operation, really keeps this response sustainable. We also regularly conduct exercises and drills together with hot washes to incorporate lessons learned back into our protocols. And this is the last slide. Special thanks to all our partners who are incredible to work with. And I'll be happy to answer questions at the end. Thank you.
Thank you, Dr. Kim. Next up, we have Doctors Booker and Kapler, who are going to be speaking to the COVID-19 remote patient monitoring program that they set up. Thank you.
Thank you. I'll get started to provide a little bit of context. Our interest in developing this larger RPM model that we're going to discuss a little bit later in the webinar really relates to our real-world experience with COVID-19 when we developed and implemented a remote patient monitoring for COVID-infected patients. We also have some peer-reviewed data that we published that Dr. Booker will share in a moment. As a practicing both dual emergency medicine and intensive care physician during the pandemic, I can say without a doubt that this absolutely improved our hospital capacity issues and our boarding. And so, if you, as many people here know about surge capacity, when you get to community level or population level events, you can't outbuild your way out of the infectious disease. You can open up as many extra ICUs you want or extra beds, but they're going to be swallowed up by the patient load nearly immediately. And so I think that this has served as a blueprint for us, using innovative technology to help mitigate those capacity issues and really changing the rules of the game by using that technology that, again, has sort of been well trod in other areas of medicine. So without further discussion on that, I'm going to hand it off to Dr. Ethan Booker, who is our system CMO for telehealth and one of the architects of our RPM model back during COVID-19. Ethan.
Yeah, thanks, Shane. You can move on to the next slide. As Shane mentioned, both of us are ER doctors, and one of the things that an emergency physician has to do is make a decision relatively shortly about what to do about an acutely ill patient. And that decision boils down to basically, does this patient need to stay in the hospital or can this patient go home safely? Our RPM program in COVID tried to do a couple of things at once. One of them, as Shane pointed out, was to decrease pressure on our inpatient units for patients who did not require that asset, but also make sure that patients that we sent home were safe. So for us, it expanded that envelope of that decision-making process to both manage capacity and to decrease risk. And as Shane pointed out, our capacity was definitely increased. We enrolled across all 9 of our acute care emergency departments, had some criteria for who was safe to enroll in this program. And just the mechanics of this just gave the patient a pulse oximeter and then staffed with a collection of medical students, MAs, and nurse practitioners that we covered 7 days a week and up to 16 days of monitoring. And then my telehealth support team provided support on the back end for enrollment and device support. So what the patient goes home with, I think, one of the things that Shane and I think is an important part of how we talk about our next program that we're going to talk about is there is obviously the ambition of how to create this preparedness, but there's also just the tactics of how you do it, what this stuff looks and feels like. So a patient view of this experience for enrollment. The patient, I said, was given a pulse ox to go home with. This was Bluetooth enabled. We helped the patient download an app before they left the emergency department, did a first round of vital checks there to kind of make sure that we had gotten that first data point from them. And then they were sent reminders on a daily basis, really simple stuff. Have you had any symptoms? Make sure you check your oxygen saturation. So we're grabbing SpO2 and heart rate data, and then saying, do you need any help with anything? And if they said, I'm having some symptoms or I need some help, that was followed by a telehealth encounter by video. So on the clinician side, each of these individual patients has a view that allows you to kind of document and engage, and that's multimodal, meaning chat, phone, and video if necessary, and then individual trending of the patient's needs. I think if you click onto the next slide, though, we'll get at what the impact of this kind of program is. You'll see a couple of red hotspots for places where we enrolled a lot of patients. That's South Baltimore, and then Southern Maryland, which is actually clustered around one of our hospitals that had a lot of cases. But just the point here is really to talk about the geographic spread of this kind of program. Obviously, we don't have hospitals in every single one of these zip codes, but we're able to deliver safe care across this entire spectrum. So I think the important part of what we want to share here is really some outcome-related data. One of the things that's inherent in a lot of the work we've obviously done in biocontainment is preparation for a patient, 2 patients. These kinds of programs allowed us to really look at hundreds of patients, thousands of patients. In our particular circumstance, you had more than 16,000 COVID-positive emergency department patients, and more than 8,000 of those discharged to home. Nearly 3,500 enrolled in some sort of RPM program. The metrics are obviously important here, but I wanted to bring home one particular story that I think is relevant to what I mentioned around discharging patients with safety. So one of the patients that we saw in one of our emergency departments, a young woman without significant medical comorbidities except for mild childhood asthma and pregnancy, she was first trimester in pregnancy, had COVID, was not hypoxic, appropriate for discharge home, left with a pulse ox, and 2 days later developed more significant symptoms and hypoxemia, was routed back to one of our emergency departments after a telehealth encounter, and eventually ended up on BiPAP and then transferred to one of our high-risk OB centers to manage her through her pregnancy. Had a difficult course, but was able to recover successfully, got to full term, delivered a healthy baby. The ability to kind of put, so like I said, expand the boundary of how you can watch these patients was a really important part of what we did. The patient feedback about this is kind of amazing. Patients who said this was really life-saving for me, this was so reassuring for me. And on the next slide, I think we'll get to what we want to kind of drive home as the point, which is, as Dr. Kapler mentioned, peer-reviewed data around the outcomes and experience. Is this effective? Is this safe? What we found was that patients who were discharged with RPM monitoring came back to the emergency department at a slightly lower rate than those people who were not monitored. But if they returned to the emergency department, they were admitted at a considerably higher rate. What that means is we identified patients who could safely be kept home and reassured them, no, you don't need to return to the emergency department. So 6.2% of patients returning versus 14.9% who were not monitored. But if they came back, they needed to be in the hospital at a very high rate. And so we were able to demonstrate with this program at scale the ability to decompress the asset of an inpatient bed that allowed Shane to take care of patients in the ICU and discharge them to the floor, but also to make sure that if we discharge someone that we could keep them safe and bring them back if we needed to. As an emergency physician who makes the decision about who's safe to go home, this was really, really satisfying to be able to know that I had some safety around these patients. So I think we'll turn it back over to you, Radu, and then Shane and I will come back a little later.
Exactly. Thanks, guys. So thank you for that interesting piece about the COVID-19 response. Yes, and we'll hear back from you shortly. Dr. Frank is going to be speaking next. She's going to be speaking to the Denver Health's virtual assessment model for at-home evaluation of suspected high-consequence infectious disease cases. Dr. Frank, please. Thank you.
Hey, thank you very much. Thank you, Radu. Next slide. So I'm going to be describing the Denver Health model for a hybrid assessment of patients that are suspected of or try to do rule-outs. So we developed this model in 2022, and it was a multidisciplinary, interdisciplinary, and interagency effort with participation of both our institution and the Department of Public Health. So what we decided was our institution is one of the 13 regional emergent special pathogens treatment centers. However, as you may all imagine, it's very, very costly, not just financially, but also for staffing purposes to actually activate a biocontainment unit. So we decided to develop a model to assess patients that are considered low risk and those who actually have dry symptoms, right? If the patient is high risk, as you can see on the right side of the screen, or have wet symptoms, even if they're considered low risk exposure, we would not do the assessment at home, and those patients would admit it to the biocontainment unit to do further evaluation and a rule out for a viral hemorrhagic fever. So for those patients that actually qualify as dry patients and low risk exposures, we would consider activation of our virtual assessment model. And our virtual assessment model will actually consist of deploying a team to the patient's home and do as well a televisit at the same time with our team in the house. Next slide, please. One of the things, and I'm going to go back, is part of the prior slide, but I'm going to be talking about it, so I wanted to continue to advance. So we have different teams that participate in this model. So we have a part that consists of the home visit, another part that is the televisit or the video visit of the patient, and then we will have extra needs, for example, if we need interpreter services as well as registration professionals to be able to set up these visits. So when we talk about the part of the home visit, we will deploy a team of paramedics as well as one of our nurses, our biocontainment trained nurses and 1 medical laboratory specialist. All of these people are trained and skilled in special pathogens protocols. So all of these people are part of our team and we train together. And basically what we do is deploy 3 different vehicles, 2 ambulances in 1 command vehicle that will transport the personnel to the patient's home. They will do a partial donning of their PPE before leaving our institution, and they will complete their donning when they arrive to the house, and they will do an initial assessment of the patient. And if the patient is deemed to be stable, to continue the assessment at the house, because if the patient is hemodynamically unstable, what they will do is get the patient into the ambulance and transport the patient to our institution for further evaluation. And in that case, we will activate the biocontainment unit. If the patient is deemed to be stable, they will do is do a physical exam guided by the provider that is in the televisit, and collect samples. And the samples will include samples for the global fever panel, malaria, appropriate cultures, complete metabolic panel, CBC, coagulation, urine, respiratory virus panel. So this is team up with the video visit. And during the video visit, we will have 2 physicians, an infectious diseases physician as well as 1 hospitalist or pediatrician. The reason why we have a hospitalist is because in our unit, the primary team that will be admitting the patient will be a hospitalist, either an adult hospitalist for adults or an adult hospitalist for pediatric patients. We do have a backup system where we have emergency medicine or critical care physicians, depending on what our staffing is on that day, but usually will be a hospital medicine physician. During this visit, they will do a whole history taken, documentation in EMR. We develop a lot of thought phrases to facilitate this process and develop a follow-up plan. The home visit team, so those who are at the home, will assess not just the patient's hemodynamics and clinical status to determine if the patient is appropriate to stay at home, but also what are the different factors at the home. Are there pets? Are there many other people in the household? Can they isolate in the household? Do they live in an area where it would be probably not safe to leave the patient? So all of the things will be assessed by the team. And if the patient is not deemed to be safe to isolate at home until we have results, then the patient will be transferred to the biocontainment unit. So what we did was perform a functional exercise. Sorry. In which we did a lot of pre-exercise work, because when we were presenting this to our colleagues, either in national meetings or in regional areas, we always had similar questions like, is it safe? Will neighbors freak out if they see all this team of people getting inside the house with the full PPE on? So we tried to do a functional exercise. The whole pre-exercise work involved actually the patient was one of our nurses, and we used the house of one of our nurses. So they actually let the neighbors know. And then we deployed the team of paramedics, laboratory, and nurse. And then we have a team of observers, some people that came from LA, some people that came from New York, as well as our public health team, to decide if this was feasible. One of the things that we noticed during this exercise is that the video visit, when done completely with the paramedics or the home team in the house, took too long. So what we decided is that after doing this functional exercise, to actually try to start doing pre-work while our paramedic nurse, like the home team is getting ready to be deployed, and doing the initial donning in our institution, to actually start with the first phone call of the first televisit, just to make sure that we collect all the history and just have a more straight line process in the house and have shorter time in the home if necessary. And well, in this case, we didn't need any interpreter services, but again, having the patient with available internet, a lot of different factors that will contribute to the decision whether the patient is okay to do the rollout at home or not. So some of the strength of this system is very similar to what you already heard from Dr. Kim. And some is like optimal resource utilization for staffing, for physical space, particularly during high capacity seasons, particularly during respiratory season, and financial. The patient is more comfortable at home. It's better for personal safety since we only deploy a small number of people to the home. It's a big collaborative effort and requires a lot of key stakeholders to participate in the design of the process. And we do have 24/7 access to VCU personnel in this model. So we would leave the patients with a follow-up plan, like when are we going to call them with the results, when are we going to call them to check how they're doing, as well as a phone number for them to call if anything changes. And it's very easy for us to convert it into a biocontainment full activation and not just do the hybrid model. So some of the challenges, there's a lot of unknowns, right? So we don't know how many household members are going to be in the house. We don't know the architectural plan. Can the patient isolate at home? Is it going to be easier for paramedics and all this big team to actually get into the house and just draw blood and do all the sample collections? What is the visibility within the community? Is it going to cause panic? Is it gonna be very easy media access? Does the patient have internet access? Can the patient perform home isolation? So all of these things are possible challenges, or all these big unknowns that will tell us whether we can activate this model or not. So one of the big challenges is that we need to identify the right patient, right? And some of the considerations, like, do we need to deploy pulse oximeter, blood pressure cuff, thermometer, an iPad if the patient doesn't have one, to actually live with the patient? Are there any legal stuff? We'll discuss it with the legal team. And for us, it wasn't a concern, but it may be for different institutions. One of the considerations is that our EMS is part of our institution. So facilitating the coordination and the response was simple for us. And we would only activate this model if it is within our deployment radius, right? We would not deploy this team if it's 2 hours away. In that case, probably the patient has to be ruled out within that area, or if there's any concerns, we need to activate the biocontainment unit. And again, for some other institutions that are not organized the way that we are, what are the local and regional regulations? What are the EMS partnerships that you have available? Those are these possible challenges that you need to assess for your own institution. And again, when we compare the traditional biocontainment unit activation versus a virtual assessment model, and when we say virtual, it's more like a hybrid assessment model. So the traditional, we can put all comers right there. It's going to be an inpatient care, and our institution is going to be led by the hospital medicine team. It poses significant burden to the accepting facility. It will be an unfamiliar setting for the patients. It will require familiarity with PPE. Of course, it will be the same familiarity for the people that get deployed to the patient's house. And it's costly and time consuming. When we talk about the virtual assessment model, it's only for low risk patients and dry patients, right? We cannot use it for all comers. It's community centered care that is led by a hybrid team, requires close collaboration between partners, because during the exercise, we did not deploy security services, but we would in a real life activation. Increases patient comfort, and it may require some additional technological and infrastructural needs. And as I've said before, there's a lot of unknowns that when we deploy the team, we may be like, okay, we're ready to do this. We're going to assess the patient at home. And then our paramedics or home team gets to the home and decides that even though the patient is stable, it's not feasible to do the model for this particular patient in this particular residence. Some of the lessons learned, it does require intense collaboration with local and state public health. And these are critical for proper implementation. We also learned that the timing of the calls as related to the EMS visits are important, just to minimize the time of the personnel that stays in the home. It's only for some low-risk return travelers, and some may still not be eligible depending on household factors. The healthcare infrastructure may not support this type of response in all localities. And the at-home isolation requires additional patient education to reduce exposure risk for family and community. And we need to make sure that this patient can isolate and understands all this education. So this model can apply to community-centered care, to a traditional hospital-centric response. And again, can potentially reduce the burden on healthcare facilities and individuals. It is designed for low-risk patients, not all travelers, and is not to be used in high-risk exposures, and even if they're dry or if the patient has any wet symptoms. For next steps, is something that we need to continue to exercise. We haven't tested it with real patients. This have all been functional exercises, so we don't know if it will be applicable, but we think that we're excited to actually test it if the right patient appears. But this will lead to continued refinement of protocols pertaining to risk stratification. We need to identify further technological or infrastructure needs, and it will require an ongoing collaboration with our public health partners. So we actually published our program in Health Security, and you can actually read. This is a lot longer than an 8-minute presentation, but you can read our whole model in this publication. Next slide, please. And thank you very much. And again, the virtual assessment model, again, is a hybrid model, require the participation of a multidisciplinary team. So I'm presenting this to you today, but there's many, many people that were required to participate to make this program successful. So thank you very much for your attention. And I will answer questions either on the chat or after the talk.
Thank you, Dr. Frank. All right, now back to Drs. Booker and Kapler, please. We're going to be speaking about the public health remote monitoring program.
So this is the goal of the program that we are continuing to develop. Much like what Dr. Frank and Dr. Kim mentioned in terms of the reasons why you would pursue this, it really fundamentally goes to two main things we talked about a little with our COVID data, but one is really providing an alternative to hospitalization and our BCU activation for stable persons. And the reason for that is, one, that is incredibly resource intensive and costly, especially if there's an alternative model to be used. And then I think the other component is the quality and safety aspects that we have all sort of hit on through the majority of the webinar. And so that's our goal here, right, is providing that alternative to hospitalization and biocontaminant activation for stable persons under investigation. And similarly, through a lot of the models you're hearing, it's through initial field assessment, and then using, in our program, a pretty deep bench of technology that allows for remote physiological and symptom monitoring and periodic synchronous audio and video assessments. In overall, I see this, the other goal of this is another tool in the toolkit for us and our public health partners to be able to mitigate this disease and improve our health security. Next slide, please. And so similarly, you'll see some commonality across all these models, but I will sort of briefly go through ours. So likewise, we have a field assessment, and that's an in-home initial assessment and specimen collection. And at the top of the slide, you see the arrow really takes us all the way through home quarantine management, again, for the appropriate individual, and ultimately for release from that home quarantine and management. You see below it, there are some very sort of specific things. So initially, our regional emergency special pathogen treatment center, along with EMS and public health, would determine that this is an appropriate candidate. The appropriate individuals would enter the home in the right PPE, complete a clinical assessment and specimen collection. As highlighted, would give us sort of early test results, and then would facilitate sort of that remote patient assessment with our respect specialists, which includes infectious disease, as well as our intensive care physicians and emergency physicians, who make up the bulk of our team. And our technology will also allow us to bring in public health partners and whoever else that would be value add. We use all that information to determine a plan for quarantine and monitoring. And at that point, if it has become apparent that this person's not appropriate because of something that's come up in that assessment, then we would sort of trigger down to the BCU activation given those high-risk findings. Assuming that's not the case, then the field assessment team would provide the patient with a remote monitoring kit and patient education. And as Dr. Booker is going to highlight a little bit more in depth what that kit looks like, essentially all that is needed is power. Everything else is taken care of. It's not internet. We're not relying on internet. This is all cellular enabled, and a pretty robust wraparound kit that provides a lot of monitoring features. A patient encounter is created, two-way communications confirmed, and then sort of the physiological monitoring initiates within that sort of disease-specific program that we have sort of developed for the various diseases. And then ultimately, that leads to disposition of the patient, which is, again, release from quarantine, after their management, or again, with this sort of tight tether and wraparound care to the patient in their home, potentially moving them to our BCU for additional care.
So as Dr. Kapler mentioned, much of this particular activation was based on learnings from our previous COVID RPM experience, but also the generosity of Dr. Kim, Dr. Frank, and kind of understanding what they had done and what they had thought about for their program. So a bit of gratitude to other programs who've been quite generous in kind of understanding where some of these pitfalls might be, and then leveraging, as Shane mentioned, a flexibility about our technology to kind of just do what we think best fits the needs of these patients. It's probably not worth detailing kind of all of the steps here, but based on my responsibility for the health system overall, which includes many hundreds of patients a day in active monitoring for other programs, we've built an expertise in how to get a patient enrolled into a program and what are the steps that are necessary to make sure that the patient has the devices they can use, that the transmission of data is secure and efficient, and that the two-way communication is reliable and usable, including things like embedding interpreters, being able to deliver prompts in language of choice, all of these things that you really have to think deeply about as you build one of these programs. The kit itself, and I think this gets a little bit at what Dr. Frank mentioned around opportunities to expand programs and what are the kinds of things that you can deliver to patients. Again, lessons learned from our COVID RPM experience was we went through several different vendors to get to a tech stack that was right for where we were. And I would really emphasize that the technology is important, but it's not nearly as important as being thoughtful about how you're going to deploy a process and what people you're going to back that technology up with. We've arrived at an LTE technology, meaning cellular enabled tablet that then is connected to these peripherals. As Shane mentioned, it's important to the way that we're thinking about this service that the patient doesn't have any requirement for internet connectivity or broadband or any of that kind of stuff. We want to take as much of that on as we can with our own technology to ensure that the patient only has to periodically plug the thing in, and then they're not relying upon them for any other work to do that. We can configure these kits in lots of different ways. The way that this particular kit is configured is mostly around heart rate, blood pressure, temperature, but we can add in scales and pulse ox and things like that. Kind of an important part of the way that we've built this program, and if you'll click to the next slide, we can kind of continue to dive in here, is this is a platform that we're currently using actively every day for care of patients at MedStar Health. So we have a group of patients under monitoring for advanced disease in a palliative care program, something called Palliative at Home, that uses this same platform. So we have already robust experience in managing patients in their homes with complex illness. That's chronic illness. It's very different than this acute deployment, but nonetheless, the learned experience for that use in the everyday, prepare for the emergency kind of philosophy that's grounded in our center has been an important part of how we've built. So the patient has that tablet experience, which is going to show them their own data, which we think is an important part of that, guided step-by-step instructions on how to answer questions and prompts, and then always the button to ask for help. And that tablet is the primary conduit for text, phone, and video for patient care. On the next slide, importantly, the clinician portal. This is really, the way that we've designed this is really around an experience of a handful of patients, one or two. But what's presented to a clinician in this clinician portal is really a population view that allows you to manage by exemption, which is the primary mechanism to manage a population under remote patient monitoring, which is really looking for flags. Flags in this circumstance are obviously vital signs out of threshold or not answered questions. And then that flag is going to draw your attention and you're going to dive into what that patient's needs are. All RPM programs kind of work this way, platforms kind of work this way. You're going to have a timestamp record of that entire patient interaction. And so when we're going to do an after action debriefing, or we're communicating with our partners in public health or CDC about what happened, we're going to have a rigorous audit log of all of the interactions that we've had with the patient and all the clinical events that have taken place. As I said, this is an established vendor with us. The vendor itself is not important, but we've learned over time that it's really important to have this stuff used every day. We have an existing business associate agreement with them, HIPAA security, all the device logistics, a financial model that's established, a cost center for billing for RPM and telehealth services, if that's a relevant way to create the financial sustainability of that, and a support structure that makes sure that when these kits go into the field, we have the ability to support them. So it would be very challenging to do this if it was not part of a system approach to how we do RPM and telehealth just generally. And turning it back over to Dr. Kapler to kind of talk about how we're thinking about deploying this program. It's ready to go, but also how we talked about partnerships in its use.
Yeah, thanks, Ethan. I think what's been highlighted also, as Ethan mentioned, standing on shoulders of giants is really that a fundamentally important component of this program has been, and I think will always remain, engagement with all stakeholders, particularly our public health partners. I do think that this is an exemplar of public-private partnerships, as you've sort of seen in the various models that exist out there. I think for us, it also, to think a little bit bigger, it tacks in with our health system. That's our health system's mission to sort of drive transformative health innovation that's going to improve well-being for our communities and our region, our nation. And we do that by leveraging our academic partnerships with Georgetown, MedStar Health Research Institute, MedStar Innovation Institute, in sort of how we hope that we can change how we respond or help shape how we respond to complex infectious threats and sort of supporting health security and resilience in the future. Because as we mentioned, I don't think we can do it with the brick and mortar approach of, let's build more units, let's build more beds, especially when you're talking about some of the special pathogens that are much more community level outbreaks, population level outbreaks, but also the resource intensiveness that comes with the VHF models that we've discussed too. And so again, going back to like, how can you break that triangle? How can you change the rules of the game where you can leverage technology that exists to improve the quality, improve the safety, and improve the way we deliver the care while keeping healthcare workers safe as well, which is an NSPS core strategy. So I think that this is the future for a lot of things in healthcare, but I also think if we can intentionally and thoughtfully leverage this within special pathogens in high consequence infectious diseases, I think it's going to improve a lot of things across the spectrum of our community's health. Ethan, please add any more of that to that.
Yeah, I think you nailed it, Shane. Again, our perspective on this really is to make sure that we're using the tools that we use every day in the care of our community, but continuing to create innovation and knowing that we do not do that in a vacuum, right? We do that in collaboration with partners on this call. We do that in collaboration with our local stakeholders and with the clinicians who have to deliver this care and that we train with. So I think, obviously I come to this from a technology perspective and enabling technology, but it is only that. It is an enabling technology, and the hard parts are really the people process that are about the change management here.
So happy to answer questions at the end as well. Next slide, and we'll turn it back over to you, Radu.
All right, thanks, guys. And if we can have all the panelists, please just come back on screen. So it looks like most of the questions have already been answered that have been posed, which is great. And I appreciate everyone taking the time to ask them. And if there's anything else that you want to ask, please put them in the Q&A section now. One question that I just wanted to bring for all of you is really this question about the stakeholders. And, Ethan and Shane, you both brought it up. And it's really vital in establishing these programs. I'm sure, you know, Dr. Frank, Dr. Kim as well. What challenges have you had with local stakeholders, institutional or your public health labs in developing these programs? And are there any lessons learned that you think would be worth sharing for our audience here in case there's something similar that they want to explore as well?
I mean, I know I have a set of stakeholders that's slightly different than Shane's. You know, again, I spend a lot of time thinking about the regulatory environment, the licensure, the compliance, many of the things that are essential for us to be able to do this work from a technical perspective. I think Shane's been the real expert on how it is that we engage with our stakeholders more broadly.
Yeah, I mean, I sort of believe in this situation, like the obstacle is the way type thought, you know, if I want to bring some stoicism into this. But I think that the need for this to be successful requires a broad swath of stakeholders, right? And also expertise. And you're leveraging, I mean, and that's across everything, right? So local, state, federal, organizations like NETEC, NSPS, the various respects. I mean, in our region, we're also very unique in the DMV, where we sort of are adjacent to multiple state and district health authorities, and you know, who have experience working together. But I think engaging with those stakeholders in the right way, it promotes more engagement, and it sort of feeds forward itself, if it will. You know, this is a sort of a tangible way to work together that sort of improves a lot of things. We also have we have a unique thing, it sounds like, Dr. Kim, with, you know, a large international airport, Dulles Airport, that sits, you know, within our geographical catchment area. And so, you know, thinking through, again, going back to that, I've said it before, but I really believe it. It's like, if the rules are kind of stacked against you and it's hard to build out of it in a traditional way, then how are you going to innovatively think your way out, you know, outside the box, if you will, and change those rules so, you know, to do what you need to do the best possible way. And so I think that's the model of this. But again, there are a lot of expertise in those stakeholders that need to sort of be brought to bear to be able to, you know, make sure you're doing that within a safe envelope, and that everyone's sort of needs are being met, most particularly the patient.
I can just add, you know, we did have a deployment to an actual patient. This was many years ago. But what we learned from that, it was a single family home and it was private. And so we could enter and there weren't any obstacles. And we did think through all that. Heat was an issue in PPE at that time. It was during the summer. And so I think somebody mentioned in the chat the weather. So that's definitely a consideration. And then I think also Dr. Frank had also alluded to, you know, whether people would be looking and coming outside and whether there would be folks trying to, you know, take pictures or whatnot. And so, you know, I mentioned that we at Public Health deploy our PIO to these types of responses and have them in our protocol, because that may be an issue. And what we did at that time that we did deploy to the home, people did come out. There wasn't as many cell phones at the time, but people were taking pictures, and our PIO just said, look, you know, your neighbor is having a medical issue and we'd appreciate you giving them some privacy. And they did go back inside, and, you know, maybe that was specific for that particular incident and it might be different now, but that is an important consideration for privacy. Thanks.
Thanks. And Dr. Frank, I don't know if you had something to add as well.
No, I was going to say that our institution is somewhat unique in which all our paramedics, and we also have Denver Public Health, is also based at Denver Health. So it's an healthcare authority. So in a way, a lot of our partners are already within our institution, which makes our collaborations and the discussion with stakeholders a lot easier. We do have weekly calls with Colorado Department of Public Health, and they actually participated in all the exercises and also in the development of the program, because they're the ones who would be, they have to agree to have the patient be tested at home, right? We can't unilaterally decide that this is safe without their okay, since they're the ones like Colorado will authorize Denver Public Health to do the monitoring. So we need to make sure that we work very closely with them. I think that having a trained team of paramedics and people that can be deployed, because some of the things is like, well, can our ambulances carry a nurse and a laboratory specialist? So we talk to legal, and because we all work under the same umbrella, actually our ambulances, our personal, like either nurses or laboratorians, will be covered if they get deployed with ambulances. But that would not be the case for every institution. So I think that identifying who our key stakeholders are to be able to deploy a system similar to this and get them involved and see what the training is going to be, what the legal obstacles would be, is key. Like, I think that we have it easier than a lot of other places because we're all under the same umbrella. But I think that, I don't know if that answers the question, but I think that everybody spoke to that, the importance already.
Yeah. I think there's unique experiences that every single institution is going to have in setting these programs up. But I think I appreciate everyone taking the time. We are at the top of the hour. So thank you again for sharing your experiences and for joining this webinar. For everyone to be aware, we're going to be sharing these slides as well within 5 days, and they're going to be on our website. Briefly, if you have any support questions, any technical support services, you can request them at netec.org or info@netec.org, and you can submit the request and to start a SPORSA and to contact us at any time for question support and services. So, and please email with any questions you may have. We're always here to help. Info@netec.org or going on to the website at netec.org to reach us. We can be reached anywhere online in any mode of operation that you choose. And so thank you again, everyone. And with that, we conclude the session.